Excellent, Marcy. Look at us. Hi, everybody. Hi. Well, we are happy to be all together here, partly in person, partly online. We expect maybe a few more people are going to join us a little bit later during the day. Today we have two great speakers, one of our own. So that's always the great pleasure to have our own faculty, and especially having our own junior stars presenting today. So really a great pleasure. We'll hear from Dr. Shields and Dr. Kuchikoni on suicidal adolescent outcomes in the Psychiatry High Risk Program, a recovery-based model of suicide prevention. So I'm going to introduce our speakers for today. Dr. Rebecca Shields grew up in the Syracuse, New York area. She attended college at Cornell University and medical school at Touro College of Osteopathic Medicine, New York City. She completed her psychiatry residency and child and adolescent psychiatry fellowship at SUNY Upstate in 2022, and then joined the faculty. Dr. Shields is passionate about helping suicidal adolescents and young adults, and serves as Associate Director of Upstate Psychiatry High Risk Program, overseeing their adolescent program. She has presented at several conferences and has published articles on recovery-based suicide prevention for adolescents and young adults. She's also passionate about psychotherapy and enjoys supervising and teaching the residents and fellows. Dr. Cook Ciccone has been with SUNY Upstate Medical University since the start of her medical school training. After graduating medical school, she remained with Upstate, pursuing psychiatry residency and child and adolescent fellowship training here as well. She has been serving on the faculty since 2021 and has engaged clinically as a child and adolescent psychiatrist in the Psychiatry High Risk Program, and she has been leading as Director of Undergraduate Medical Education, serving as a Psychiatry Clerkship Director. Dr. Cook has presented at national meetings such as the APA and ADMSEP, which is the training, the program for directors of the clerkships, and is passionate about adolescent mental health, psychodynamic psychotherapy, and training our future physicians and psychiatrists. Just want to emphasize Dr. Cook has really been leading the clerkship program amazingly well, and we are very proud to have Dr. Shields and Dr. Kuchikoni as our faculty. With this, I want to extend warm welcome, and we welcome learning more.
Wow, thank you so much. And thank you everyone for coming today, both in person and online. Before we get started, I did want to mention a few people who have been really key here. So thank you to Dr. Gregory for his help on this presentation. And let's see if I can advance it. Nope. Oh, now it came. Okay. All right, and then also Dr. Glatt and Jessica Helfrich for their work on these projects that we'll be talking about. And of course, we would also like to thank the entire Psychiatry High Risk team for the hard work they do every day for their patients, and they're here right now supporting. Thank you. So we do not have anything to disclose today. These are the objectives for today. We would like you to be able to better appreciate the scope of the adolescent mental health crisis, be able to apply general principles of DDP and recovery-based suicide prevention to the treatment of suicidal adolescents, and also to be able to summarize or have an idea about the outcomes of suicidal adolescents in the Psychiatry High Risk Program. So first, we wanted to start with the adolescent mental health crisis. I'm probably, preaching to the choir about how bad things are, but just to give you guys some context, according to the CDC Youth Risk Behavior Survey in 2023, 40% of teens experience persistent feelings of sadness or hopelessness. 20% seriously considered attempting suicide. 9% attempted suicide. And then the subgroups, the female and LGBTQ plus students were more likely than their peers to experience persistent feelings of sadness and hopelessness, poor mental health, and suicidal thoughts and behaviors. And suicide is also the second leading cause of death in the 10 to 14-year-old age group, and the third leading cause of death in 15 to 19-year-olds in the US. Worldwide, I believe it's about third or fourth. So here's a bar graph showing some of the differences as well by demographics. So again, we see that females are at higher risk of at least seriously considering attempting suicide than males. And we also see that LGBTQ plus population being much higher. And then a few ethnic differences as well, with American Indian or Alaska Native being the highest risk, followed by white and multiracial. So I wanted to show this slide because I recently had been going off of the CDC's 2021 youth behavioral study. And honestly, this gives us a little bit of hope. So if you notice, the trend has started to come down, at least for females who experience persistent feelings of sadness or hopelessness during the past year. And so while the 10-year increase is sad, we also may have some hope for the future as well. More on the adolescent mental health crisis, suicide rates among adolescents climbed 62% between 2009 and 2018. And this one I know affects a lot of you in different, in the emergency settings especially, that suicide-related emergency department visits increased fivefold between 2011 and 2020. So how are we dealing with adolescent suicide? Well, I would say the community, and probably standard in most of the country, is kind of a chronic illness model. When we see the adolescents, we work hard to make an accurate diagnosis, and we manage those symptoms, usually with meds, neuromodulators, or counseling, such as noticing there's depression and looking at how can we treat the depression. And then, of course, we also want to manage risk. So a lot of us do intense, safety planning. We also do crisis interventions. We think about hospitalizing. And these are all good things. However, it does not really fully address the biological and psychosocial determinants of suicide, and therefore suicide remains a chronic, recurring risk. So this may pack a punch, but one person dies by suicide every 11 minutes in the US. And so by the end of this presentation, we will have lost 8 more people to suicide. Suicide risk remains elevated at least 10 years after hospitalization in this chronic cycle of recurrent ED visits and hospitalizations. So it's this cycle that we're trying to break. And of course, the missing word in suicide prevention is really recovery. We know about risk mitigation, symptom management, recurring hospitalizations, but can we break the cycle of chronicity to provide this transformative healing by maybe addressing what's underneath it, the underlying vulnerabilities, maybe psychological, social, and neurobiological factors? What is recovery? Well, SAMHSA defines it as a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Some of the main principles they've identified are hope, holistic, and person-driven. So this is where we come in, maybe. And it says saving and transforming lives. And this is to introduce our Upstate Psychiatry High Risk Program. Fortunately, Dr. Cook is not represented in that picture, but these are a lot of members of our wonderful team. And as we talked about before, we work with suicidal youth and young adults. Who are we? So we're an outpatient program. We are self-supporting, multidisciplinary. That means, we have social workers, case managers, psychiatrists, nurse practitioner, and all our clinical staff are trained in dynamic deconstructive psychotherapy. So we have tight quality control as well. We do quarterly outcome measures. We record all of our sessions, and we meet every week in small groups to have peer supervision amongst us so that we can continue to stay in frame and get better and be more effective for our patients. And we also have a recovery focus. We really strive for transformative healing, building resilience, and breaking the cycle. Again, instead of this idea of symptom management, stabilization, and brief interventions. So how well is it working? How well is the program working? Well, we have had over 900 patients treated and only one death, which is one more than we would want, but also less considering all of the suicidal patients we treat. Patients have come from as far away as Georgia, Texas, California, Chicago, and SAMHSA designated it to be a best practice in suicide prevention. We've also received the American Psychiatric Association's 2023 Silver Award for Psychiatric Services and have found that our program is sustainable, scalable, and potentially replicable. So what is dynamic deconstructive psychotherapy? This is our primary modality of the treatment. It's manual-based and available on the website there, www.upstate.edu/DDP. And it involves weekly individual 1-hour sessions. It's time limited, so the weekly sessions go on for 12 months, and it's kind of has a soft landing, as we call it, so they're able to transition to monthly visits after that. And then we also supplement with medication management, family therapy, group therapy, outside groups like AA, and more, if they want it. And then also, you know, the question then is, what is this indicated for? I think a lot of times people have thought of DDP as being attached to BPD, or borderline personality disorder, and that's true because that's what the randomized controlled trial showed, especially with co-occurring substance use disorder. However, with this rising, suicide rates and, not just in adolescents, but also in adults, we really wanted to expand who we are able to help. And so now we see, transdiagnostically, anyone with suicidality at the PHRP for the most part. What is the adolescent division? Are we any different than the adults? What I can say is not very different. It's nearly identical. And I think the reason is that adolescents naturally deal with these same issues regarding things like autonomy, identity, self-worth, emotion processing, and relationships. And all of these are addressed in DDP. So in some ways, adolescents are naturally kind of made for this therapy in that, these are all things that they'd be struggling with anyways, even if they didn't have, let's say, a mental illness. What are the differences? Well, we just have slight adaptations to the recovery commitments for adolescents and parents. So we have recovery commitments for the parents as well, and that's so that they can actually help support their adolescent in doing the program. And then we have some initial parent involvement, and then again at the 3-month rating scale check-in time periods. We strongly encourage family therapy, but it's not mandatory. And this has pros and cons. I think that family therapy can be extremely beneficial for all adolescents and families. At the same time, sometimes families, don't feel like they can take the time off to engage in another treatment. And we don't have any current DDP specific group therapy for adolescents. We have done that in the past and had varying levels of numbers of adolescents in the program at a given time. But as of right now, teens and parents can join our monthly psychoeducation sessions. And they also have access to case management services, which we are so thankful to have added this past year. Okay, so getting back to who's eligible for DDP. Well, someone has to be willing and able to engage in weekly psychotherapy. Some of the common diagnoses we see are, major depressive disorder, BPD, anxiety, PTSD, bulimia, OCD, anorexia, bipolar disorder, and schizoaffective disorder. For the people that I would say it's relatively contraindicated for would be those with severe or acute psychosis or developmental disability. Those who are severely malnourished, we know that, people with severe anorexia who are still in the malnourished phase, aren't able to get enough nutrients to their brain to really engage in a psychotherapy. They really need to be fed first. And we've seen that on studies. And then the other, possible contraindications would be frequent ECT or esketamine. And then, of course, logistical challenges to attending sessions. If someone's not able to get to your office every week or attend appointments on a weekly basis, then it's hard to receive the treatment, right? So DDP is a psychodynamic psychotherapy. And some of the influences are from psychoanalytics, especially object relations with Kernberg and Winnicott, self-psychology by Kohut. And then also it's really heavily influenced by neuroscience, especially the idea that the emotion processing systems of the brain and Jaak Panksepp's work in affective neuroscience. And then there's also an influence by Derrida's deconstruction philosophy. These are the studies that have been published so far around DDP and the Psychiatry High Risk Program. So as you can see, we have several on the theory of it. And then we do have 2 randomized controlled trials. And we are in the process of being in our 3rd right now. And then we have some other kind of pre-post or comparative trials and papers. And of course, the mechanisms and also on training. And we also have a couple of papers in process now, one of them on BPD in adolescents, and also one on treatment-resistant depression. So how does DDP differ from other therapies? Well, this may sound strange, but the goal is not to resolve crises, to improve symptoms, or reduce maladaptive behaviors. Our stance is not directive or validating, and our task is not teaching new coping skills or behaviors, problem solving, recounting trauma, or making interpretations that link past to present. So what are our goals? These all seem good. Well, our goal is recovery rather than symptom mitigation. The stance is non-judgmental rather than directive or validating. And the task is to remediate the determinants of disease, the core vulnerabilities that's underneath the symptoms. So sometimes we'll tell our patients that, our goal is not, can we manage your depression or anxiety, but rather, can we help you to process things differently, to see yourself in a new way? And through that process of connecting with oneself, those other symptoms can go away. All right, and now I'm going to pass this on to Dr. Cook.
Thank you, Dr. Shields. Okay. Oh, thank you. So one of the definitions of suicide that we like to use in the program, borrowing from Durkheim and interpersonal model, is stuck alone with overwhelming pain. So I'm going to talk about how we use that definition to work with the individuals who are dealing with suicidal thoughts. So our goals for this recovery-based treatment address that stuck alone by helping them build connection. We inject hope into our patients so that they can believe that things are going to get better, that there is a possibility to recover, not just manage and cope with what they're dealing with, but actually have a new life and be doing what they want to all the time. And that they can have relationships that are authentic and real and close and meaningful, while they are still able to be true to themselves as an individual. And then we address that overwhelming pain by helping them build resilience. We strengthen their ability to adaptively process emotional experiences, and we help them reconcile to their sources of pain. So DDP addresses two core vulnerabilities that drive stuck alone with overwhelming pain: emotion processing deficits and embedded badness. So we do have evidence that those who have gone through stressful or traumatic experiences have had changes in the emotion processing system of their brain. There's downregulation in the prefrontal cortex. There's increased activation in the subcortical limbic structures, such as the amygdala and the ventral striatum, leading to symptoms such as panic and hyperarousal in seeking out kind of immediate rewards and solutions to their pain. So in DDP, we try to build capacity for verbal representation of their emotions and experiences. We help them develop a more complex schema and understanding of themselves and increase their perspective. This is versus how their brain's been reacting all along with hyperarousal, reactivity, dissociation, and impulsive pleasure seeking, such as seeking out drinking or dependent attachments. So, how do we do this? We have individuals recount and elaborate recent interactions instead of their overgeneralized memories. I can't tell you the number of people that come into my office and say, well, this always happens. You know, my mom's just always on my back about everything that I need to do, or everyone's always mean to me. So those are like those overgeneralized kind of lumped together memories. So instead we help them get to specific recent interactions, which helps remediate their autobiographical memory, help engage more of that development in the hippocampus. And we help the clients label their specific primary emotions in those interactions. And this goes beyond just anxious or upset. So for those of you who are in supervision with me are probably pretty familiar with me talking about, okay, so yes, anxious was their kind of overarching feeling, but what was underneath that, you know, or upset, what's upset mean? That could be different things depending on the situation or what that person's experiencing. So I'm going to use myself as an example right now. Okay, so I'm up here giving a presentation and I'm feeling very anxious in this moment, which is true, I'm very anxious, but I want to get underneath that to the specific primary emotions. So if I were to label my own emotions right now, you know, I think I'm a little worried. I might make a mistake or make a fool of myself, but I'm also kind of excited to share about this with all of you and for you to hear about our outcomes in our program and maybe get you excited as well. Maybe I'm a little frustrated that I agreed to do this because, you know, I could be doing different things right now. And so there could be a lot of different emotions underneath that anxious right now for me. And this is what we try to help our clients do as well. So these are some of our tools that we use to help them develop an increased vocabulary for their emotional experiences. So we provide them with a in-depth emotions list and we encourage them, but again, not making them do anything, but welcome them doing daily connection sheets where we have them describe a specific interaction, a recent encounter, and then try to get in touch with the specific emotions underneath that interaction. So that's how we kind of address more of the emotion processing deficits. And now I'm going to talk a little bit about embedded badness and how does DDP address this. So that embedded badness is this underlying, often unconscious sense that they are defective, evil, bad, ugly, unlovable. And so as you can kind of see in this image, which terrifies me a bit, but that's that kind of sense inside of you that there's just this evil inside that is trying to get out. So that embedded badness has some different components to it. It often can have self-doubt and rejection sensitivity, and that leads to internal conflicts regarding justification and seeking external validation. So these kind of internal conflicts allow them to have these questions of, do I have a right to be angry? Are my needs legitimate? And they're going to seek external validation to solve this internal conflict. And you'll see momentarily how we get that back inside of them to resolve. And this also leads to things like mood reactivity, depression, and suicidality. So how do we do that? Well, we try to maintain a judgment-free zone. We provide genuine caring and avoid shaming interventions. And we respect patient decisions, especially those that we disagree with. But the idea is that it's not our decision and it's for them to resolve and figure out for themselves. And this will help them kind of resolve their self-doubt, because then we can let them know through those interventions that they really are able to figure this out themselves. And we help them identify those internal conflicts and work through them without taking sides. But if we take one side of the conflict, then they're going to take the other, and then it's not going to get resolved. And that's what's been happening for them lifelong. The other component of embedded badness is hiding, a defensive avoidance of self-awareness. So there's a defense that's kind of blocking them from being more aware of themselves. And this will lead to things like distraction, using drugs or alcohol, or dissociation and splitting. So if you take dissociation plus that self-doubt, it's going to lead to split conflicts of justification. So here's some more examples like I had just mentioned. So these are conflicts our patients are often grappling with in our sessions. Am I responsible for every bad thing that ever happened in my life, or is someone else to blame? Do I have a right to be angry, or is this all really my fault? Are my needs legitimate, or am I just a whiner? That one comes up often. Do I prioritize my needs or the needs of others? Another one that, I mean, all of these come up pretty frequently, I should say, and I think a lot of us might even have some moments where we kind of question these things as well. The underlying emotions here are anger and shame. So how do we address this? Well, we ask about possible split off alternative meanings or emotions. And we ask them to hold those opposing meanings or emotions simultaneously, so that you're bringing into awareness different parts and different thoughts and feelings into the conscious awareness. All right, so here's an example. I like to say, check your countertransference. And this is something I ask my trainees all the time. All right, what was your countertransference? Like, what were you feeling kind of pushed to do? So here's our example for this case. Patient's parents are on her back for getting her homework done, and the student is failing. So inside us, we might feel strongly to validate the patient side. Your parents are the worst, they're overbearing. Yeah, this is no good, you're depressed. This is just gonna make you feel worse about yourself. So they're really blaming the parents and joining the patient and blaming the parents. Or we might feel pushed to invalidate the patient side and take the parent side. Well, you really should be doing your homework because that's how you're going to succeed in school. How else do you expect to get by? That's only going to make you more depressed if you fail school. And then that's putting the blame all on the patient. So instead of taking a side one way or the other, we ask about opposing emotions such as anger and shame. We help them hold them together. We help them question if there is part of them that blames their parents or blames themselves, and kind of help them explore alternative meanings or areas of blame. Another component of embedded badness is hiding with defensive avoidance of authenticity. So there's this false self, alienation, and emptiness that results. Here's another example. So the patient, while crying, is saying, I'm good at acting around my friends. I can pretend that I'm happy and everything is okay, but on the inside, I'm really a hot mess. And the therapist would respond, so is it hard for you to know whether people value you for who you really are, given that they might not be seeing all of you? And the patient responds, yeah, it's like if anyone really knew me, would they like me? So instead of reassuring the patient that people would like her, oh, I like you, you're a great person, you just got to get yourself out there more, we would help the patient verbalize her own concern about her value, whether she questions if she's valuable or not, especially if she's kind of putting on this false self. And in the therapeutic relationship, the teen has both a longing to be understood, but a great fear of vulnerability. So it's really hard to feel close and true and authentic, at risk that they won't be accepted or valued or cared for. The other thing that can happen with embedded badness is that it leads to enactments, which then leads into negative schemas and recurring maladaptive relationships. So is it possible to respond differently than what our patients expect? Or are we just human vending machines? They push our button in one way and out pops the response that they're expecting and what they've been getting all along, and kind of go on like that. So can we be different than just a point and click and response? So some of these dilemmas up here on the screen might be some that you're all familiar with, and probably could add more to this list. But these are often the dilemmas we see for suicidal individuals. I don't want to recover, I just want to die. Nothing is going to help, I need more help. I don't have anything to talk about, I'm just depressed. I want to work towards recovery, but I have a secret stash just in case. I'm not sure I can keep myself safe, but going to the hospital is just going to make it worse. If you discharge me, I'm going to kill myself. And I'm too depressed to do the things you want me to do. I don't have the energy or the motivation to do what you're telling me to do. How is that going to be helpful to me? I don't have the energy for it. I'm coming every week, but nothing seems to be working. Cool. I don't know about you, but some of these even bring up my own reaction in myself just reading them. So checking my countertransference here for a moment. All right, we'll come back to that in a little bit. All right, so here's what can happen with that common suicidal dynamic. The irredeemably bad patient meets helpless rescuer. So there's a regressive wish to be cared for and understood by an idealized clinician. And then they add in the fears of unveiling and revealing themselves, again, that false self. So there's desperate pleas for help, but passive resistance to our interventions. Either the interventions can't, or the patient can't do them, or the interventions just don't work. And then we try more interventions, and then those fail, and then the patient feels more hopeless and suicidal all along with that. And then the provider is in the role of helpless rescuer, and the patient is still at high risk. So our countertransference, as I was mentioning, you might have been noticing yours as well. If you feel hopeless, you feel paralyzed, feel trapped in responsibility, and then you feel helpless though and frustrated. You feel desperate, frantic interventions to the rescue. I'm going to prescribe these different meds or these different interventions. Like there has to be something that's going to help this person. I'm very scared that they're going to die. And self-doubt. Well, maybe I'm not good enough. I got to refer them to someone else. Like I can't do this. This is not going to work. And fear of tipping them into suicide. I have to be very careful. This person's right on the edge. If I say or do the wrong thing, they're going to end their life. And then I'm going to be to blame. So how do we deconstruct these dynamics? We work to foster individuated relatedness and work through ambivalence. So the ability for them to be their own individual and still be close and related with you as another person. So these are the kind of three processes that we do this through. We treat them like responsible adults, create a transitional space for authentic individuation, and provide deconstructive experiences. And you're like, all right, that's all good, fine and good, Rachel, but you're talking about adolescents here today. How are we going to treat them like responsible adults? Well, as they're working through development and becoming their own individuals, that's the path they're on anyway. So why not help them and facilitate that so they can do it in a healthy and meaningful way for them? So even with our adolescents, we really do want to foster as much ownership over their treatment as possible. And this relates back to that principle from Sansov's definition of recovery of it being person-driven. So recovery really needs to be within the person, and they need to be the driver of their recovery process. So I emphasize the word "their" in here, like elicit their chief complaint. So we often get teenagers in here and you're like, okay, how come you're here today? My mom wanted me to be here. Or my therapist said that if I don't come here, they're going to discharge me. I have no other option, right? And so those are like what brought them in the door, but is that really their chief complaint? Is that what they want to work on? Now, maybe they want to work on getting their therapist off their back or their mom off their back, but really trying to help them develop that chief complaint. Well, what, if anything, if I could help you, what would you want to see different? Since you're here anyway, what is it that you would like to see change for yourself? What would you like, what would be your wish if this could help you in some way? So really trying to work with them to develop their own chief complaint, which really allows them to take ownership over their goals. Now you're working towards what they want, and they're going to be more on board with you. And you also want to lay out a formulation and a clear path to recovery, and then invite the patient to join you on that path. So they must choose. So you can, lay out the most beautiful plan possible, but really if you're the one saying, okay, this is what we're going to do, they haven't necessarily bought into it. But if you allow them to choose and again, make that decision, then they are going to have more ownership over their recovery. And we want to be collaborative with them. We really want to avoid the should word. We're not here to tell them what to do or make decisions for them, but really allow them to figure that out and make those decisions on their own. But of course, as the further down bullet point mentions, we're not going to not tell them negative consequences of certain actions or decisions. And we're not going to be like, yes, you can certainly go and drink and drive. No big deal. I'm not going to tell you what to do. No, we would still lay out the potential positive and negatives of certain decisions that they're making. But we really want them to be the one to decide what they want to do. And so that, therefore, we keep the conflict in them rather than kind of earlier talking about our buttons being pushed to take one side or the other. And we want to respect their opinions and decisions, especially those we disagree with. It's not, our path, it's theirs. And, we want to be respectful of what they're choosing, while also sharing about those consequences. And we review recovery commitments with them, which again, helps them take on their ownership of their own health, treatment, and recovery, which is right here on this slide. So these are adolescent recovery commitments. So these are commitments they're not making to us. They're not making to the high risk program or DDP or their parents. It's the commitment they're making to themselves to get to their goals that we were developing in the initial sessions. So they'll come regularly and on time to their weekly sessions. They're going to actively participate. This is not a passive sit back and let the therapist tell you what to do treatment. And that they bring something to explore, such as recent interactions, thoughts, emotions, behaviors, and they can bring in things like creative works or dreams to explore as well. We do ask that there is no hostile behaviors, as that can end up worsening the therapeutic relationship as well as how the patient feels towards themselves. And we ask, are you ready to work towards health and recovery? And not just in our sessions, but also between this and kind of overall for yourself, working in that direction, which includes admitting yourself to the hospital when necessary, taking medications as prescribed, getting medical care, and keeping themselves safe. And we do have after-hour phone calls, but we have some limits on that, and we do not allow texting, as that can often lead to misconstrued information and potentially burnout for the clinicians too. And then the parents also have their own commitments on how to support their adolescent in the treatment process. So ensuring that their child gets to their appointments on time, but also really this is a big one, helping their child develop a sense of ownership for their treatment by encouraging them to make their own telephone calls and address any concerns directly with their providers during session. I think this just came up with one of our cases we were supervising where the kid asked mom to ask the therapist, hey, can you, or the psychiatrist, I want to change my medication. And so the mom then asked the psychiatrist about the medication change, but we would really want to try to help the child ask for a medication change or discuss it in the therapy session so that that parent would kind of direct their child back to the psychiatrist directly. And also involved with this is limiting their contact with the child's individual therapist to concerns regarding safety. So like a significant deterioration in condition or acute safety concerns. Otherwise, they start to play more of a role in the treatment, and it makes it feel unsafe for the child that their therapist is not someone that they necessarily can trust and confide in if the parent is kind of there influencing what's talked about or asking about what's talked about. We really want this to be the individual's treatment so that it can be their safe place. And then as mentioned earlier, we do really encourage regular family therapy while someone's in the program. And the pair commitments also include tips for helping the adolescent in crisis that are within our frame as well. So what are some other ways that we deconstruct those suicidal dynamics we talked about earlier? We want to create a transitional space for authentic individuation. Again, natural adolescent development, they're starting to become their own individuals. They're figuring that out. So this is a space where they're allowed to do that and can really truly explore who they are. We do this through providing a caring and judgment-free zone where they're free to explore and connect with their experiences without worrying whether or not it's going to meet with our approval. Now that might drive them a little crazy sometimes. They want to know whether or not we approve, or they want to know our opinion. But the idea is that we don't lay out our thoughts or opinions either way so that they can really be the one to figure it out for themselves. And they choose what to explore. And we try our best to avoid control struggles, again, trying to keep the conflict about what to do within them so that they can develop that sense of autonomy and confidence and ability to make these decisions moving forward. And we non-judgmentally explore evidence of ambivalence, so such as missed sessions, disengagement. And we paint a target on ourselves welcoming disagreement or criticism, which I'll describe a little bit more here. I think this is one of the more challenging techniques that I was learning DDP. How do I really invite in someone's anger or frustration with me? But here are some examples of that. We will welcome any negative or mixed feelings towards you or the treatment. So for example, a patient's complaining about his or her family, they're minimizing what they're going through, and then the therapist might respond, I wonder if you sometimes feel that I also minimize what you're going through. Another example, experiential acceptance, the patient might state, you don't care about me, you only see me because you get paid. definitely have had that one before. And I know people I've supervised have had that one before, and really brings up a really tight feeling in my stomach. And I get really frustrated because I'm like, of course I'm here to be, taking care of you. And I'm not just here for the paycheck, especially when you're a resident, you're like, I'm not getting paid enough to be doing this. So, that like your buttons are going to get pushed to have that kind of reaction. Instead of kind of being like, you got to be kidding me. Of course I care about you. I want to be here to help you. The response that you could do within this frame would be, thank you for sharing that. What is it like for you to have a therapist who you think just wants money and doesn't care about you? And I'll just make a little emphasis right there that who you think. You don't need to like completely throw yourself under the bus and say that you don't care about them, but who you think wants money and doesn't care about you. And then we want to provide deconstructive experiences. You want to respond in a different way from how your buttons are pushed. You want to break out of that vending machine costume that we saw earlier. And your countertransference is your compass. Especially for suicidal clients, you want to challenge them to choose whether or not to engage in recovery. And so that breaks that dynamic of the helpless rescuer. Again, it's not your choice, it's theirs. So have them choose, are they ready to break out of that a path of going towards suicide and illness? So here's an example. Patient might say to you, I feel so depressed, nothing's helping me. Clinician responds, are you feeling frustrated with me for not providing the help that you need? Patient, what are you going to do? I know you were trying, but there's nothing you can do. Clinician, why do you think there's nothing I can do? Patient, you just can't make me feel better and want to live. Of note, the patient has been disengaged in treatment, not bringing in material to explore, and missing many sessions. What is your countertransference? How would you feel in this interaction with this patient? Feel free to pop up and say something if you want. Anyone? Anyone else have any different reaction? Yeah. Yeah, maybe irritated, desperate, irritated. Anyone else? Sorry. Oh yeah, so get rid of the, yeah, move them on. Well, this isn't helping. I'm just going to get rid of them. Yeah. All right, thank you. All right, and I think I have it on the next slide, but just thinking of like, what would be the best intervention? All right, there we go. We can you can shout out letters now, but I'll read through them. All right, let's look at this together. Your beliefs that your condition. Oh, sorry.
Oh, do you want?
Well, no. Well, now I have it. Maybe not yet, Abby. Thank you. You can answer. You can shout out a letter once we go through the responses here. Fair enough. All right, let's look together at your belief that your condition is untreatable and see if it really fits the facts. Now, some of you might say that. B, you have a lot of stressful issues going on right now. Just stick it out and things will start to get better. You are clearly depressed. We need to think about trying a different antidepressant. What's it like having a therapist who can't help you? Or E, that's the question you need to answer for yourself. Do I want to live and get excited about life? Or do I want to work towards death because treatment's so difficult and just not worth it? All right, got some E's. Any other ones? Maybe, yes, C. All right. So how about this? This is what the therapist might respond. Remember that at the beginning of the treatment, we had reviewed the recovery commitments? Those aren't random rules. They are the minimum commitments necessary for this treatment to be helpful in meeting your goals. Some of these commitments are to work towards health and recovery, to attend regularly, and to actively participate in treatment. But what I have seen is that you are not attending regularly, you aren't doing the daily connection sheets, you aren't bringing in material to explore, and you haven't started exercising or volunteer work. I realize that it's extremely difficult to do the things necessary to recover when you're feeling so depressed. And you may decide that the treatment is worse than the disease. And I totally respect that it may not be worth it to you. The path to recovery is very difficult. But if you are tired of being depressed all the time and want something better for yourself, there is a path forward, and I would love to work with you towards achieving your goals. But I respect either decision. You just need to decide which way you want to head. All right. So again, trying to put the conflict back into the patient to decide. We're not there to tell them. We also respect. Maybe we disagree. That happens all the time with me. A patient decides that they don't want to continue treatment and continue working towards recovery, and that's really painful. And it saddens me when people choose that way. But I also respect their decision, which is really hard. So again, that example of respecting their decision, even in those that you disagree with. So these are all examples of association techniques, so sequencing and labeling emotional experiences, attribution, exploring and integrating alternative meanings, and alterity, experientially foster individuated relatedness. And so all of you that are currently in your third year getting trained in DDP, you're practicing these, and I hope that you can continue to grow and get that experience, because we really have found it to be beneficial, which is what Dr. Shields will be talking about next.
Thank you so much, Dr. Cook. And now I'm going to end us out with the PHRP adolescent outcomes. And we will take questions at the end as well, so we'll get there soon. So the first study we wanted to share with you is our 6-month suicidal adolescent outcomes. And this was recently published this past year. And so we had 65 consecutive suicidal adolescents at the PHRP, that's the Psychiatry High Risk Program, and they were ages 13 to 17 years old. Our primary outcome measure was the Columbia Suicide Severity Rating Scale, suicide ideation, which is out of 5. And then what we found with this population when we looked is that 98% of these adolescents had over 2 years of psychopathology already. And 78% of them had self-harming within the past 30 days. And even bigger than that, they had a median of 7 lifetime suicide attempts. Again, this is our adolescent population that we're working with here. So this is a big chart, and it may be hard to read, but on the far right, we have the D column, which is the effect size, and then the P for statistical significance. For effect size, a small effect would be 0.2, medium effect would be around 0.5, and a large effect would be around 0.8. And then, of course, you know that as you can see, the statistical significance was less than 0.001 for all of them. And so if we look, we see that suicide ideation had a large effect size of 1.19, and then depression, improvements in self-compassion, self-harm, their perceived disability from their symptoms, anxiety, and then suicide attempts had a moderate effect. And, you know, I was reading previous articles, and it is hard to get a large effect for suicide attempts. We would love to get even better. But so far, I don't think any paper that we had seen, or the review at least, hadn't shown positive effects for suicide attempts themselves. We also looked at utilization in this study. So we found that we had a 69% reduction in the mean number of ED visits, and also a 67% reduction in the mean number of hospitalizations. This is important, especially for a self-sufficient kind of program. They're trying to demonstrate that this may actually be cost-effective as well. I'm excited to share this study. This is a paper that we're working on right now, and it involves the 6-month outcomes for our suicidal adolescents who also have borderline personality disorder. So we looked at 108 consecutive suicidal adolescents at the Psychiatry High Risk Program. And again, they were ages 13 to 17 years old. And we found that 87 of them, or 81%, met criteria for borderline personality disorder. And we didn't just look at them and say, oh, they're borderline, or, you know, something like that. You know, the psychiatrist and psychiatric practitioner, you know, went through all the symptoms with the adolescents. And then also they get extra testing with the SCID-2 or the SCID-5. And along with that, we actually look at length of time for having the symptoms. The DSM-5 says that they can have the symptoms they need to have the symptoms for at least 1 year. We wanted to be more conservative in this population, said 2 years. So these were the number that met criteria based on at least 2 years of symptoms. And these adolescents with BPD, compared to the adolescents in our program without BPD, had more suicide attempts, more drug use, more functional impairment, more childhood adversity, and worse alliance scores with their therapists. And they also, although it wasn't statistically significant, trended towards more severe suicidal ideation, depression and anxiety, lower self-compassion, and greater difficulty identifying emotions. So along with looking at the characteristics of this population, we also wanted to look at the outcomes for these suicidal adolescents with BPD. So at the start of treatment compared to the 6-month mark. And again, we have the same columns on the right with the D and the P. So the effect size and the statistical significance. As you can see, so the best on the far left, that's our first row. That's the borderline estimation of severity over time. So that's how we tracked the severity of the borderline personality disorder symptoms. And that was one of our primary outcome measures and had a large effect size of improvement over just 6 months of treatment. And also with the suicide ideation subscale again, that also had a large effect size. As you can see, suicide attempts, medium effect size again, and then the rest all large effect sizes, again, for depression, anxiety, self-compassion, alexithymia, and disability. So this was promising because although this population is sicker in many ways, they also were able to make use of the program and of the treatment. I'm excited to share this. This is a quote of an adolescent I worked with previously, and I thought, based on our recovery approach, I thought this quote kind of fit well for today. So she said, "I feel like I've been able to process my emotions better, and I like that it's a recovery model and not a chronic illness model because it gave me a lot of hope. I like this program better than the other programs because it's helped me develop a sense of me. It's helped with my borderline personality disorder, and it's helped me identify my emotions more. It's a consistent choice. Like you can't be 1 foot in and 1 foot out. Every day it's like, do I want to work towards health and recovery? The biggest change has been not being suicidal and feeling like I know who I am." So here's some more resources. Again, the site is very similar to the DDP site, but instead of /DDP, it's /PHRP. And then we also on the site have the free manual, web-based training modules, and we also can offer individual or group weekly case consultations and trainings. Also very exciting, we have an upcoming book called Therapeutic Dilemmas with Suicidal Clients, in the process of writing still, but that's exciting. And then I also have our contact information on here. And feel free to Google the high risk program as well, because some of the patients now have left reviews, and it's just really encouraging, at least for me, to read them and how it's changed their life. Here's some of our references. Thank you.
Thank you, thank you. Thank you for this wonderful presentation and for the really hard work that you've been doing. I'm going to start now Q&A part of our talk. I know we already have several comments in chats. Okay, Dr. Curry was helping us with, thank you for that. And then, thank you, we can divvy this up. Oh, maybe, Marcy, maybe just to give one to speakers. Here we go. Okay, we are ready for questions. Please go ahead.
Dr. Strayhorn.
Thanks very much for that. I was having a conversation recently about why so many psychotherapy outcome studies exclude suicidality from their study. And I think the main reason is it's too stressful for the investigator. You get called at 3 in the morning and you're got worries about getting sued if somebody kills themselves and so forth. Uh, and it tends to make people wake up worried about people. And I'm curious to hear about your self-care portions that you've built into your operation. And as one of those, I wonder if the whole notion of keeping the conflict within the patient is an important part of that.
Thank you. Yes, I would say you hit the nail on the head that I would say I don't feel comfortable working with suicidal patients except for in this model. And I think one of the key parts of it is to keep that conflict in them to decide, do they actually want to work towards being alive or not? Because that's something that we can't really decide for them. I wish I could save someone's life in that way who doesn't want to be saved, but I don't have that ability. And so knowing that and not pretending like I'm more powerful than I am really helps with that. And I also think for me, and I'll let Dr. Cook share too, I think the team-based approach is very important as well. We do, Dr. Cook and I have our doors, across the PHRP, we have our doors open so that we can come help each other if needed and run, scenarios by each other. We also have those peer supervision groups every week. And it's just helpful knowing that we're all in this together and can help each other out. And then, of course, I think the recovery commitments themselves provide this framework so that we can work with this population. So one of them is around phone calls. By giving our cell phone numbers out, yes, we put ourselves at risk for getting those late night calls and weekend calls. At the same time, we limit it and we contain it. We tell them up to 2 calls a week during waking hours. And when we're not available, we give them the suicide, risk emergency services numbers. But I think it's just a nice act of caring to be able to give that out while also containing to be able to, limit it so that we don't get burnt out.
Thank you. We have more questions in chat and then we'll turn to Dr. Hargrave. So the question we have is, how do you manage adolescents who are dissociating in your office?
Good question. It's challenging. I think that one thing we know from studies is that when people can label an emotion, their hyperarousal and the amygdala, the amygdala calms down essentially. And we know that just labeling an emotion can do that. And so, whereas maybe other programs will focus on things like breathing and or counting, which is all fine, that's good too. We kind of focus, at least I do, on are there any feelings coming up right now? And sometimes the big list can be overwhelming. So I might draw out 4 kind of big players like shame, anger, fear, and sadness, and have them point to one. So I have found it to be effective. Even I work with adults as well, and I've had some, they're all over the room knocking on things, totally dissociated, won't sit down. And, eventually by asking them, they have been able to kind of get back into the moment just by connecting with their feelings.
Thank you. Dr. Hargrave, please go ahead and unmute yourself.
I have done that. Thank you for this excellent presentation. Things have really evolved since I was a student wanting to learn DDP. And I'm wondering whether you have yet been able to get insurance coverage, especially Medicare, Medicaid. Insurance coverage.
Yes, no, thank you. Sorry, we were just wondering. Yeah, so it wasn't us personally, but yes, we do have coverage. We do accept Medicaid and we have a whole list of Yeah, Fidelis and Melina, thank you. I was just like, some of the directors might know the answer better than myself, but yeah, so that's how we are sustaining ourselves is through insurance reimbursement. And so we do try to keep an updated list of the accepted insurances on our website too, but it is, being reimbursed and covered by insurance companies.
Thank you. We have more questions. What is your success rate using the DDP modality with transgender youth?
So our research coordinator, Jessica Helfrich, actually presented on this at one of our conferences for psychotherapy, and Dr. Gregory might know better, but essentially results are a little bit worse, but overall effective. So we see a little bit of a difference, but it is effective and does work. Dr. Gregory, do you want to add anything?
And maybe comment why worse? Yes, here he is.
Yeah, I would add there was a slight difference. It actually wasn't statistically significant in outcomes, and which is a good thing because we have a large percentage of our adolescent population, as you might expect, given the data Dr. Shields presented earlier, a large percentage who are transgender or non-binary. So I think it's about a third of the adolescents who we see there. So I was very concerned actually about our outcomes in that population because they are higher risk population, and was happy to see that we're still able to address, there's enough overlap in vulnerabilities that they're still able to benefit from the program.
Thank you, Dr. Gregory. We are receiving many comments thanking for a great presentation, for excellent work, for having case management as part of the program. Dr. Hargrave, more questions?
Yes. Akin to the previous question about transgender youth, I'm wondering how the population breaks down for race and ethnicity, and especially since you're the entire team that the slide showed was seemed to be white. Are you having any success in recruiting and treating persons who are BIPOC?
I can start us off. We had a wonderful woman who we were hoping to recruit who said yes and was so excited to join us. And then unfortunately, something happened with her child. And so she had to move out of the area for specialized treatment. So I agree. I think it's really helpful to have a much more diverse team than we have. And we all hope for that. And we have some more spots opening up. So, hope that someone can join us. In terms of our outcomes, we always controlled for, race and ethnicity, and they were not statistically significant in terms of, how they did in the program. However, the large majority of the patients we treat, I believe it's 80% are Caucasian.
I think we are at a bit of a whim of who does get referred to us, as well too. And so this will be my plug to, encourage, individuals to think of us and encourage individuals you think that could benefit from this treatment to seek our treatment out too. So I know we try to coordinate with our teams and the consult office and inpatient units. So certainly, welcome whomever wants to seek out this treatment as well. Like I know that we've had different patients from the nation, and certainly welcome anyone. But I know that insurance, like as you mentioned with your question earlier about like Medicaid as well, like certain insurances do end up being a barrier at times. One of the downsides to being based solely on billing.
Thank you. I think our team at Inclusive Health Services is asking if possible to get the data or stats on the impact of treatment in transgender youth. Certainly, we can connect you with IHS and help with that. Dr. Meyer?
Thank you so much for this wonderful talk. I particularly like what you broke down sort of some of the advanced psychodynamic concepts and gave really practical advice. And I think that's one of the strengths of the DDP program in general. I was curious about what you thought in terms of next steps for the data. Are you thinking about maybe doing a trial where you compare it to DBT or a different psychotherapy modality or treatment as usual, however you want to do that, or in terms of how long the effects last? I don't know where to go next. What are you thinking?
So a couple of the things we have right now coming up specifically is that, the BPD adolescent study, and then also a treatment-resistant depression study. And then also we're in the midst of a randomized controlled trial for DDP for suicide prevention compared to BIC, which is not well known, but is actually by far the best established treatment for preventing suicide, and actually is the only study so far that has proven to decrease suicide deaths. But that is not a specific therapy per se. It's more of a program to kind of help. It's based on getting people connected to treatment and providing support and things like that. So, and that's the World Health Organization backed suicide prevention program. I believe that our adult study, one of the studies did include a comparison with DBT. That is definitely something that I would love to do for the adolescent population as well, but not to kind of compare us per se, but more to show that maybe there's some, kind of work together on that, and that there may be some adolescents who respond better to DBT. And then what do you do with those that don't respond to DBT? Well, we hope that they'll try DDP next because they're pretty different. And then in terms of how long do these effects last, we would love to do that too. We're trying to keep our patients who are in monthly maintenance and get their longer term outcomes. So far, I would say they're good, but again, it's hard because we just don't have a big enough N yet. And also it's hard once you lose people to follow up. So I do hope that future studies can include, maybe the finances to support that and to be able to really look at longer term outcomes, because that is our goal. It's right. It's not just to help them while they're in treatment, but can they actually recover?
Thank you. We have another question from IHS. Any limitations related to hormone replacement therapy while in treatment?
So part of our role is to not weigh judgment either direction for an individual. Again, trying to maintain that non-judgmental, neutral stance, and really to help an individual fully explore themselves. So this can include how they feel about their gender, their sexuality, however, they're identifying and feeling secure in themselves. And so the support exploration of self and identity, again, including gender. What we have found, and a bit, this is from our experience working with different individuals, is that no matter what treatment they seek that could be significant and potentially life-altering or changing, they're going to have emotional reactions to that. They're going to find that there are ways that other people respond to them that bring up reactions within themselves. And so for any type of treatment that could be very significant, a very large decision, we want to equip them as well as possible to make that decision and be able to cope with the results of how they feel about it and how others respond and react to that. So we're not necessarily saying that they, cannot do anything. And again, we don't pass judgment either way in what they want to do, but we want to well equip them with the ability to cope with anything that could be life-changing for them. So for example, someone, could be having, unrelated to their gender identity, could be having significant surgery for a breast reduction, for example, but being able to cope with the recovery process of having major surgery and how others might respond or not respond, maybe not giving them support, and do they have the own internal resilience to manage that. So the idea, again, is just about making it so that an individual can have that inner resilience to cope with any transition that's going on in their life, anything significant or life altering. And we're not going to say you can't do, hormone treatment or you can't have any transitions during your year, but that we really would like to work with you to explore it and feel like you are in the most stable place possible prior to making anything life altering.
Yeah, I just want to add that there are many people in the program who come in at various stages of their journey, with surgery or hormones, and they're allowed to come in at whatever stage. I think where the question is coming from, which is fair, is that we don't write a letter to support for the surgery until after they've done the year of DDP, and then we tell them yes, we'll see where they land and support what they've come to. And again, that idea is to really help them to really know themselves and to already have worked on emotion processing and to be able to just kind of take it in stride, whatever way it goes. So it, and it's not about not believing people, coming in who are very, have been consistent, persistent, about their choice, but it's also about the expectation of, a lot of these individuals are all suicidal. And so sometimes there's this expectation that the surgery or something will change their life and be the one thing that's missing. But oftentimes that's not the case. There are other things that need to be healed as well. And so we kind of help temper or dampen those expectations a little bit to be able to look at it as one aspect of themselves and not the only thing that can maybe save their life.
And actually, just because I'm reading it now and I was trying to do it from memory, but yes, they are able to continue or start treatment. It's not necessarily, again, something that we would start ourselves, but just explore with them.
Definitely take the insurance too.
Thank you for the response.
Thank you. Thank you, Jess. And thank you for very comprehensive answers. We still have a little bit of time. Any remaining questions that we have for our experts? If not, I just want to emphasize we are very thankful for your work, your hard work. We very much appreciate your contribution and learning from you, and we are looking forward to keep following. Thank you.